Okay, let's get started. Anyone else can join later. Good afternoon, everyone. My name is Alana Sadri. I'm a program coordinator at PCMCH. Thank you for joining our webinar series for the Pediatric Diabetes Network and the Ontario Pediatric Bariatric Network. Before we begin, I'd like to let you know that towards the end of the webinar, we will have a dedicated Q&A. So feel free to type your questions anytime in the Q&A box located at the bottom of your screen, and we will get to as many as possible after the presentation. With that said, it's my privilege to introduce you to Dr. Juan Espinoza, who's going to talk to us about the role of wearable devices in supporting family-based pediatric obesity interventions at a federally qualified health center. In 2014, Dr. Espinoza became an assistant professor of clinical pediatrics at Children's Hospital Los Angeles and the University of Southern California Keck School of Medicine, where his clinical time focused on complex care coordination and obesity management, while his research focused on informatics, medical devices, health equity, and global health. His overarching career goal as a researcher, physician, and advocate is to identify, refine, and innovate approaches to using data and technology to improve health outcomes and narrow the health gap faced by marginalized communities in the U.S. and abroad. Most recently, Dr. Espinoza joined Lurie Children's Hospital of Chicago as the inaugural Chief Research Informatics Officer and Associate Director of the Center for Biomedical Informatics and Data Science at Northwestern University. And in this new role, he provides expertise and oversight of research informatics. So I'd like to give a very warm welcome to Dr. Espinoza, and we will pass it over to him to begin his talk.
Great. Thank you so much, Alana, and good morning, everyone, or good afternoon. My name is Juan Espinoza, and I'm going to go ahead and share my screen so we can get started. Please feel free to leave your questions in the Q&A box as I'm going. That way you don't have to worry about forgetting or remembering them at the end. I tend to talk fast, so I will do my best to speak at a reasonable speed, but my goal is to leave plenty of time for discussion and questions. Great. So with that being said, we're going to jump right into it. But I wanted to do my land acknowledgement and let you know that I am in Los Angeles, California, in the traditional lands of the Chumash and Gabrielino and Tongva nations here in Southern California. These are my disclosures. I received research funding from FDA, NIDDK, NIMHD, NICHD, and NCATS, and I'm also a paid consultant for Sanofi. Sanofi played no role in any of the work that I'm going to be discussing today. So today we're going to talk about the digital divide as a concept and understand the role of physical activity trackers in obesity interventions and talk about some strategies to incorporate these technologies in low resource settings. We did a little bit of introduction. I'll do a little bit of background. We'll talk about the BodyWorks Fitbit study, which is the subject of today's talk, and then some lessons learned, and then we'll leave time for questions and feedback. I realize that this is a group of individuals who have significant background in obesity, and so I will try to do my best to go quickly through my obesity slides, since it feels a little bit of the old preaching to the choir. So let's jump right into it. Many of you are familiar with diagrams like this. And when we think about social determinants of health, I think it's a really critical place to start, because we're going to be talking about federally qualified health centers, marginalized communities in low resource settings. And so it's really important to have this framework that the conditions in which people are born, grow, live, work, and age are really significant drivers of their health and their health outcomes. And as we think about those, we have these concepts of sort of moving from sort of the equality to equity to justice as we think about delivering care and addressing the systematic barriers that individuals face in their lives. And so I think it's really important to think about the conceptual map of social determinants of health and embedding that within the socio-ecological model of health, and we'll come back to that. In the US, we use this framework, or one of the frameworks that's commonly used is Healthy People 2030, which breaks down social determinants of health into 5 categories: healthcare access and quality, social and community context, economic stability, neighborhood and built environment, and education access and quality. And then you can think about all 5 of those domains at each of the levels of the socio-ecological model of health and how they impact individuals, interpersonal relationships, organizations, communities, and societies and policies. So having that framework is really helpful as we think about why we do the things that we do. And why it matters specifically in the space of technology is that if we don't have this concept of social determinants of health and health equity and health justice, is that as we develop and deploy more and more technology advancements, we're going to create bigger and bigger divides, and the health gap between, as this report from the Children's Health Fund describes it, between the haves and the have-nots, is going to get worse and worse. And we've seen, surely this report is from 2015, and we've seen certainly that happen during the COVID pandemic and in the rest of our healthcare environment, where individuals with better access to technology and to internet, that tends to correlate with socioeconomic status, and it tends to correlate with health outcomes. And so we need to address those critical foundational gaps, and we need to deploy technologies in meaningful and intentional ways that help support marginalized communities. So it's helpful always to sort of talk a little bit about obesity and how we think about it. Again, this is a group that probably knows more about obesity than I do, so I will be brief. Usually when I start talking about this, I talk about sort of the classic model of obesity for a long time was, calories in, calories out, nutrition and physical activity. And over time, we started thinking about behavior playing a really important role, but then really thinking about all of these other concepts that are related to those three that really play a huge role, right? So stress and sleep and mental health and parenting and socioeconomic status and the built environment that families find themselves in. And of course, these things are not discrete, they're all interconnected. And so they influence each other, and of course, the pathophysiology of obesity itself. And so you can sort of map the old concept of nutrition, physical activity, and behavior into these other pieces. But of course, these are not the only things. There's also genetics, and there's neuroendocrine regulation, and there's myokines, and of course, the role of public policy and all of this. So thinking about obesity as sort of the socio-ecological model really helps us place each of these things, both whether there's sort of these internal physiologic or pathophysiologic processes, the environment and the behavior that environment permits or does not permit, and then the policies and the organizations around it. So the definition that I like of obesity is that it's a pathophysiologic process that results from an abnormal upward regulation of the body's fat mass set point, and that the physiologic changes that we see in obesity are what drive behavior, and typically not the other way around. I won't spend too much time here. As all of you know, obesity has a number of complications, and one of the reasons why I was interested in obesity is that obesity is now the most common chronic disease of childhood, and in the U.S. costs about $14 billion a year. We know that earlier age of onset of obesity is related to a number of comorbid conditions, which are becoming more and more common in younger and younger children. Childhood obesity is the #1 predictor of adult obesity, and adult obesity is associated with increased healthcare expenses and decreased lifetime earning potential. And so, as such, obesity is a contributor to perpetuating the cycle of poverty. And so, I think that's why we were so focused in finding meaningful ways to intervene. So, what is it that we decided to do? Well, let me tell you about the BodyWorks Fitbit study. So, to give you a sense of where this study takes place, so this is at the Ultimate General Pediatrics Clinic that is associated with CHLA. It is a federally qualified health center that does probably about 100,000 visits a year. These numbers are a little bit out of date. About 27,000 unique patients. 93% of those patients are publicly insured via Medicaid, and almost a little bit more than 3/4 identifies Latino, and half of those families primarily speak Spanish, so have limited English proficiency. So that's the clinic where this study takes place. It's where I practiced for nearly a decade before moving to Chicago. And so we had at the clinics a program called BodyWorks. Bodyworks is an evidence-based curriculum that was developed by the US government, by the Office of Women's Health, that's part of the Department of Health and Human Services, in 2006, and then was updated a couple of times based on new data. We ran it as a multidisciplinary team, so we had physicians, occupational therapists, dietitians, mental health as needed, and the general structure was these were weekly sessions for 8 weeks. Each session was 2 hours, and it was a group format where parents and children attended together. And we tried to, again, make this as easy as possible for families. So we encourage the entire family to attend. There's no cost for the program. If the family had concerns about childcare, we said, great, bring all of the kids, including the lean siblings, right? Because everybody can learn healthy eating habits. We encourage them to bring other adult caretakers. A lot of our families had multiple adults in the home. There might be aunts and uncles or grandparents who also participated in childcare, and so it was important for all of them to have access to the information. And we ran the program on Monday, Tuesdays, and Wednesdays, and so families would be cohorted into a given day, and usually Mondays and Wednesdays where the entire group was run in Spanish. On Tuesdays, the group was run in English. Realistically, it was actually run bilingually. And we tried to keep the cohorts to 5 to 10 families so that there'd be enough time really to have some meaningful interactions with each other. So why personal activity trackers or Fitbits? Well, this is sort of our conceptual framework. And the basic concept is, so the parent and child participate in these programs. And the physical activity tracker is really enabling some classic behavior change techniques, right? Social support, by being able to share the activity, their weekly activity data. It enables self-monitoring because the patients are able to review their own data. We could set goals based on the data, based on steps or active minutes, and then we could do coaching. So families who got a Fitbit, we would meet with each adult individually. We'd review their weekly data and talk about setting specific goals. And this was, really basic observational stuff. So, for example, we'd look at the last week's days, and the person doing the coaching would look and say, for example, it looks like on Thursday you had 12,000 steps. That's amazing. What did you do on Thursday? And they're like, on that day I decided to walk instead of taking the bus. And they're like, great, that sounds fantastic. Do you think you could do that again this week, or could you do that twice this week? And so it would be very, very straightforward, data-driven coaching. And so those major behavior change techniques were applied at the parent. The parents are the ones who got the Fitbit. And the goal was that through these behavior change techniques, we would increase their engagement in the program. If the parents were more engaged, the child would be more engaged. And so you'd have this positive role modeling and joint participation. And we believe that engagement would lead to decreased attrition, which was our proximal outcome. And decreased attrition would lead to increases in target behaviors and eventually lead to improved weight-related outcomes. So that's our conceptual framework of why we wanted to try the use of personal activity trackers in our study. I'm going to be presenting data that's a mix from 3 different publications. I'll make my slides available so you don't have to remember these citations, but just wanted you to know that we've now published 3, almost, and the process of 4 manuscripts looking at different aspects of this trial. So in terms of the study design, this is what families participated in. As I mentioned earlier, there was an orientation and then 7 weeks of participation. Each session was 2 hours long. At the first 30 minutes, we did a quick check-in individually with each family. There's an opportunity for the parents to ask, on a one-on-one setting, any medical or questions that they had for a physician who was associated with the program. That's when we also got their anthropometrics, collected their Fitbits, uploaded the data, made printouts for them. Then we had 30 minutes of physical activity and exercise, where everybody together did exercise in whatever way they were capable of doing it. We often did, sometimes we did yoga, sometimes we did more intensive exercise. Then we purposely would do a snack. And that snack was an opportunity to do our nutrition education. For a lot of kids, they were coming sort of straight from their after school programs. They may not have had a snack. For some families, the snack was an important part of their overall food budget because they were struggling to make sure that they had sufficient food at home. So we wanted to make things easy for them and to be able to participate. And then the snack itself was always a healthy snack. We often used it as a time to teach cooking skills or to teach about food labels. And then we split the adults and children into two groups and did our education on the topic of the week. And so you can see on the right the various topics that we covered, sort of this concept of healthy weights and healthy habits, that, you know, healthy eating, portions, physical activity and screen time, cooking and shopping, and then planning for the future. In terms of the actual Fitbit data, so the parents were during the orientation visit, we consented participants for the study. If they agreed to participate, if they were randomized to receive a Fitbit. That's the time that we would give them the device. This was, it feels quaint now, but so the study started in 2015. And at the time, at least our institution's IRB had a pretty conservative definition of COPA, which is the Child Online Privacy and Protection Act, and what the terms of use for Fitbits and Fitbit data was. So we were not allowed to give Fitbits to children under the age of 13. So only the parents got them. And then a few adolescents, we gave them Fitbits as well as part of sort of a sub-study. But in order to prevent any identifiable information being the Fitbit account, we basically created all of the Fitbit accounts using, dummy email addresses. We had all the usernames and passwords. And again, in 2015, when we were doing this and smartphones were not as ubiquitous, or so we thought, we actually, instead of having the patients pair the devices with their own phones or their own computers, we paired them all with computers at the hospital. And so every week we would get the Fitbit from the families, we would upload their data and then give it back to them. And we did ask participants not to create their own accounts because it would disrupt the study's ability to collect data. To then extract the data, because we had created all of the accounts, we used Python, which is a coding language, to write some script that would basically query the Fitbit data API. And then based on the list of username and passwords that we had, we then were able to extract all of that data into CSV files and then compile all those CSV files into a master data set. This is the way we did it. There are lots more sophisticated ways to do this now. There are companies like Fitabase and others who will basically, if you're using Fitbits or Withings or any other personal activity tracker, that you can use to basically manage all of the data on the back end. But if you've got somebody on your team who knows a little Python and is not afraid of the command line, you can get it all done for free and get the exact same results. So this was our consort diagram. So we ended up having, during the study period, which lasted about 2 years, we did 10 cycles of bodyworks. Remember, each cycle is 8 weeks long. So during that time, we had 174 families who enrolled in the bodyworks program. 16 of those families were excluded, so 158 actually participated. They were block randomized by language group, so we didn't want to have cross-contamination because the entire intervention is group-based. We didn't want within a group to have some families with Fitbits and some families without. I think it creates it would have interfered not only with the group dynamic, but also with potentially with the data collection. And also just from an equity perspective, we didn't think that was fair to anyone. So we would randomize the entire group into either control or intervention. And so we ended up having enrolling about 66 families in our control and 92 families in our intervention program. And then you see the dropout and completions there. By the way, we're presenting this data at the family level. This is how many families participated. I will call out when we're doing the individual child data. So in terms of the participants and the demographics, our participants were really representative of the clinic and the population that we cared for. So overall, 93% of participants identified as Hispanic. We didn't really present, and this was in conversation with our patient population. We didn't present other race and ethnicity data, at least in the way that lots of other studies presented, because again, it was not really relevant to the community that we were caring for. And we didn't really see much of a difference in terms of ethnicity between intervention and control. In terms of limited English proficiency, it was a slightly higher in the intervention group, but overall, again, sort of representative of the population. And then household income, I think just what's the most striking is just the percent of families. So almost 80% of all families had lived in a household that had an income that was less than 200% of the federal poverty limit in California and the US at that time. When we looked at the individual children, so these 158 families had 225 children who participated, a little bit more female than male children participants, on average about 11 years old, and a BMI percentile at baseline. These numbers may seem low for an obesity intervention, and that's because we're presenting both the healthy siblings as well as what we call the index child, which is the one who has obesity, who was referred to the program in the first place. So in terms of what we saw of actually participating in the program, out of the 7 sessions, so not including the orientation, in general, the intervention group attended, attended more sessions than the control. And when we looked at it, tried to look for other types of correlations, we saw when we looked at control versus intervention, or looking at English versus Spanish, we didn't find, not many of these were statistically significant. We did see some interesting trends, which is particularly among the Spanish language group, the families who were primarily Spanish speaking, they, although not statistically significant, they were more likely to complete body works if they were in the intervention arm, if they had a Fitbit. When we think about the actual availability and use of Fitbit data, we saw one of the things that we tried to measure from a data quality perspective is how many days, how often did we have valid data? And valid data was basically any non-zero number. A number of a zero on a day meant that they didn't wear the Fitbit, or the Fitbit wasn't charged, or it wasn't working. In general, a pretty even distribution, although something that sort of surprised us is on the weekends, on average, we tended to have a little bit less data, and midweek we had more data. It's likely because people forgot to wear them on the weekend, which is too bad, because that's probably when they were most active. And we saw higher numbers sort of midweek, which kind of coincides with the fact that that's when the program sessions were, and so people were more likely to remember to wear it. In terms of participants who had Fitbits, who actually had, how many of them even, what percent of their data was valid? By that meaning, again, non-zero days. We were worried that for this study, folks would forget to wear their Fitbits, or they would forget to charge them, or they might lose them. And in general, we were pleasantly surprised. In fact, the majority of families wore their Fitbits at least 50% of the time. And so that was really good, and really only 34 out of 130 or so individuals who actually received Fitbits. really wore their Fitbit less than a quarter of the time. So in general, we had reasonable uptake of the intervention, of the actual use of the intervention, which was reassuring. In terms of their experiences with the Fitbit, by and large, our participants, they liked it. They thought it was comfortable to wear, it was easy to charge. They thought that it was helpful and they felt more motivated by using it. Many of them thought that they would want to consider getting activity trackers on their own. Again, 2015, 2016, when the ability to do some of these things, even just natively on your phone, was less common. One of the things that we were really interested in was what was the overall technology access among our community. And so every family, or as many of the families as possible that participated, we asked them to complete a technology access survey. And so we asked them, we wanted to understand, what their use of various forms of technology. So we, and even back then in 2015, the reality is most of our families had, 98% of them had a smartphone, and 98% of them were text messaging, and more than 80% of them had unlimited data plans. Interestingly, email was one of the things that they used the least, but they were much more likely to be on either social media or to be texting. And so that helped inform sort of how we thought about our interventions and how we shared information. That we were more likely to call or text or do things on Facebook than we were, say, in sort of sending email reminders. And part of the reason, again, that we did this is that there was a perception that, in low resource settings, families are less likely to have technology, to feel comfortable with technology. And so really we wanted to sort of show that that was not the case, that actually technology, not only was technology present, but that the community really embraced the use of technology, but maybe they use that technology differently. And when we looked at sort of our participants compared to the US averages for the same period of time, is that actually ownership of smartphone was much higher among our participants than it was in sort of the US as a whole, with a slightly higher percentage of Android users, but again, that decrease in email use. So you're probably wondering about weight outcomes. I don't talk too much about the weight outcomes because if we looked at all children who participated, and we looked at their change in baseline and post-intervention, yes, the families that were in the intervention arm lost a little bit more weight as measured by BMI Z-scores. This is the child weight at this point, I should clarify. But the reality is, both the control and intervention groups lost weight. B, once you controlled for the number of families who actually completed the whole program, so it attended at least 5 sessions, that difference between the control and intervention group disappeared. And that is, I think, not surprising. It helped us. I think what we learned from this process is that the personal activity trackers in and of themselves are really not a tool for weight loss or for obesity intervention. That's one component, is that really that they are tools of engagement. The device enables the family, gives one more way for the parent and the family to feel engaged with the process by using those behavior change techniques of goal setting and self-monitoring and coaching. But that in and of itself, that doesn't do much if you already have somebody who is engaged and motivated. So that's why that's our interpretation, our understanding, especially as we talk to the families who participated. And that's why once we adjusted for those families who had high completion rates, who attended most of the sessions, we didn't really see a difference between control and intervention. The other thing that's a little bit messy about this data, as many of you know, it's not clear, especially in an 8-week time point, what should be the weight loss goal for children? Depending on the child, usually it's much more personalized, depending on the child's age, baseline weight, and comorbidities. The goal might simply be to decrease the velocity of weight gain. It might be to stabilize weight. Weight loss itself is usually not necessarily the goal, especially in younger children or in children who are in that sort of class 1 obesity stage. It's usually behavior change. So I think that's another reason why I think it's worth taking the sort of the baseline to post-intervention weight change with a grain of salt. Is again, that it's only 8 weeks. It's a varied group of children ranging from having overweight to class 3 obesity and sort of everyone in between, and across various ages, so 6-year-olds to 18-year-olds. The other thing that we found that was interesting, and I wanted to highlight here, is that we had a surprisingly high proportion of families with children with autism spectrum disorder participate. And what we found is that for the children, for those families as well, there was no difference in their ability to participate in the program. In a lot of programs in the past, this is less common now, had as an exclusion criteria children with developmental disabilities. And really through our program, although it was not designed that way, one of the nice things, because we did collect that information, one of our collaborators, Jasmine Orozco, who is one of the authors on this paper, is an occupational therapist with a special interest in children with autism spectrum disorders. And so on a whim, we ended up, we said, oh, well, we should track whether our participants have any kind of IDD, and are there adaptations we can make to the program to make it more accessible and more inclusive. And what we found is sort of as a secondary outcome of this research is that really children with ASD, families who had children with ASD were able to enroll and complete the program, basically the same as their typically developing peers. They have the same weight outcomes, and they had the same engagement outcomes. So what's interesting for us was that not only is the BodyWorks program, but also the Fitbits sort of worked the same in both in these communities as well, which was, I think, a nice thing to have found through our work. And if you're interested in that piece, in this manuscript that was published in Autism, we talk at length about the modifications, the accessibility modifications that we made to the program to ensure that families with ASD could participate. So I want to spend a little bit of time talking about lessons learned before we get to the Q&A. So I think the things that were, certainly when I look back on this program now with sort of, 6 years of hindsight, I think one of the things that we could have and should have done better was really to enable patients to have control of their devices and their data more regularly. They were wearing the Fitbits and using them sort of in a blinded manner, so they weren't seeing their daily steps except by the lights on the actual physical device itself. And given the impact that we saw of the ability to self-monitor and of the coaching, I think giving them the access, and of course, lots of literature that's been published since then, that families really should have access to the devices, they should have access to the data, and they should be able to check on it as frequently as they want. And I think we may have seen bigger impact in that way. The coaching, the data-based coaching, I think was really, really well received. A lot of our families spoke about that. They also enjoyed sharing the results with each other. We would every week, in the parent group, everybody would share their total steps for the week, and the person who got the most would win, a small prize. And that piece of sort of community building, I think went a really long way. It was competitive in a pretty even keeled and collegial way, which I think was for a lot of parents remarked that that made a big difference for them, that they enjoyed that. I think the other piece that I think we struggled with was, or rather we struggled with at the beginning and then we quickly addressed, was we did have, even though the rates of smartphone ownership was high, the use of the ownership of computers was really low among our community. And again, an early Fitbit, before they had launched their apps, you had to sync the device to a PC. And so that was, we learned very quickly that we had to do all the syncing in the hospital because of that. And then sort of within a year of our study start, Fitbit had released their mobile app. And then all of a sudden it's like, oh God, well, do we adjust our study design to enable families to use the mobile app? We decided against it. And that was a real struggle, because now families could download the Fitbit app. And we actually had multiple families who had basically downloaded the app, connected the device to that, created an account, and then we no longer had access to their data. So then that got tricky. And so we had to figure out ways to do that. But I think that goes back to my first point. We're really, from the beginning, empowering families to have access to the devices, to have access to the data, and have that transparency with them really made a whole lot of difference. And really, I think at the end of the day, what we're talking about is really just, it's meeting patients where they are, right? The technology solutions are available, and they can have an impact, but they need to be tailored to the community who's going to be using them. And we need to take into, they need to be active participants in the design, the selection, the overall program, how you're going to use that technology. Without their voice, without their participation, I think there are a number of operational challenges, and there are a number of adoption challenges. And so I think that really the most important thing that we learned was really how important it is to work with the community and be real partners in that community-based participatory research framework of doing this work together for the ultimate goal of helping to improve the health outcomes for them. With that, I'd love to open it up for questions here in the Q&A, and then if you wouldn't mind, I'd love to get your feedback on my talk today. So I'll put this. Oh, there is no chat today, but there's a QR code on your screen, and there's a URL there. There's a very brief survey just to give me some feedback on the talk today. But